Yes.
Just,
Oh, yes.
just every day we want to just do a constant affirmation of how amazing you are. Honestly, it helps.
I'm absolutely
We're just
amazed
saying
every time we see
amazing,
these
isn't it?
people. I can't believe it.
I know, amazing.
Yeah. Yes.
Sorry.
Hot tub today, especially.
Testing 1, 2, 3.
Are we all right? Good morning, everybody. May I ask you please to check that your mobile phones or any other electrical equipment you have with you are on silent mode. We're in level 1 evidence today, so members of the public and reporters in the hearing room are not permitted to use any electronic devices during the hearing. If you do wish to do this, you can do so in the annex. Legal representatives, please remember that though you are allowed to use such equipment in the hearing room, you may not transmit anything to the outside world until 10 minutes after it has been said or displayed. These are important requirements which are the subject of the Chair's ruling and a restriction order. Breach of such orders is a criminal offence. For those viewing in the annex, you will not receive any information until the 10-minute period has elapsed, so you may transmit information as soon as you see it. No food or drink may be consumed in the hearing room except for the water provided. Those people seated in the public gallery may not cross into the legal team area. If there is a need to pass the message on to anyone in that area, please write a note and give it to one of the ushers who will deliver it for you. The usual sitting times for the inquiry are 10 till 4:30. Lunch will be approximately 12:45 to 1:45, and there will be short breaks mid-morning and mid-afternoon. Please wear your lanyards and passes at all times within the building, and note that if you leave the secure area of the building, these will need to be handed back. On re-entry, you will have to undergo a further search, so time will be limited. Also, please remember that those viewing proceedings in the annex will still have 10 minutes for the hearings to go when we finish the hearing here. So please try to be quiet in the entrance lobby when you leave. Our ushers are here to help you, so please ask one of them if you have any questions. Some of the evidence to be heard in this inquiry may be upsetting, and we have volunteers from the Coroner's Court Support Service who are available for confidential discussions if anyone is affected by anything said or shown during these proceedings. Perhaps the support workers could please indicate who they are. They're in this room. There we are. Thank you. Please, if you need their services, please approach them directly or ask an usher. Finally, may I please ask you to remain seated at the end of each session until the chair and witness have left the room. Thank you very much. We will be starting proceedings very shortly.
Ms. Pottle.
Sir, you have before you Professor Nolan and Dr. Soar. Please, may they be sworn.
Yes, gentlemen, I'd like you both to take the oath, if you would. Just stand to do that and then sit down again afterwards.
You've got to repeat after me. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that
the evidence I shall give
the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
and
nothing but the truth.
and nothing but the truth.
Sit down. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that
the evidence I shall give
the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Please sit down.
Thank you, sir. Now, you've written a joint report, so it's apparent that you agree about much of the material that's likely to be covered. But you will understand, of course, that you've each taken your separate oaths. You each have your separate expert's duty to the inquiry. And should there appear anything on which you don't agree, you must say so. In the meantime, presumably you've worked out a way of dealing with the content of your report with one of you speaking rather than both, have you?
Yes, sir, that's
Right.
the plan.
Thank you very much.
Dr. Soar, could you give us your full name, please?
Dr. Shazmeet Soar.
And Professor Nolan, could you give us your full name?
Professor Jerry Nolan.
You have together written 2 reports in this case concerning the cause of Dawn Sturgess's death, the standard of care given to her, and whether any delays in treatment contributed to her death. Those reports, if we can bring them up, please, are inquiry reference 5994. It should come up on the screen in front of you. That is the front page of the report. And if we could turn now to page 123, please. Here we have the declaration. The declaration is we confirm that in respect of those parts of the report to which we have contributed, we have made clear which facts and matters referred to in this report are within our knowledge and which are not. Those that are within our knowledge we confirm to be true. The opinions we have expressed represent our true and complete professional opinions on the matters to which they refer. And underneath that, it's been redacted in this version, but is that did you sign this page of the report, both of you?
Yes.
Yes.
Thank you.
Okay. And if I can now bring up the addendum report prepared in this case, it's inquiry reference 005995. That's the first page. Do you recognize that? Just on the screen in front of you.
Yes, we do.
Yes. And then if we turn to page 5, We have again the same declaration which we saw with the first report. And did you both sign that declaration there
Yes.
on that second report?
You look as if you've both got hard copies of the reports in case you need them. That's fine.
Yes, we have.
Yes, okay. So may both of those reports be adduced into evidence?
Yes.
Professor Nolan and Dr. Soar, I will ask you each questions in relation to this report. I will address my questions on different topics to one of you, and I would ask that you answer that question. But if the other, who's not been addressed directly for that question, has anything to add, then of course, please indicate and you can answer following on. So hopefully if we take it in stages like that, we'll avoid talking over each other, which is very challenging for the transcriber. Never mind the rest of us. Now, before I get into the reports themselves, I would just like to discuss firstly your expertise. You are both preeminent in your fields of specialty with long and successful careers. Dr. Soar, I'll start with you. In the report, this is the first report, reference 5994, we have on page 3 a summary of your expertise. We could just, might be helpful if we could zoom in fact. Thank you very much. You are a medical doctor, and your specialty is intensive care medicine and anesthesia, is that right?
That's correct.
You are a consultant at Southmead Hospital, North Bristol NHS Trust, and you have been since 1999, is that right?
Yes, that's correct.
So you have, and you remain, in fact, in full-time practice, caring
Yes.
for critically ill or injured adults, is that right?
That's correct.
Okay. You have clinical experience regarding the causes of cardiac arrest, survivability and prognosis, including in patients following drugs overdoses, poisonings, and brain hemorrhage. Is that right?
That's correct.
And you were, for a time, the medical incident commander for a major incident in the Avon region from 2001 to 2013, which included multi-agency exercises, including CBRN incidents. Is that right?
Yes, in the early part of my career as a consultant, it was a role that was sort of handed to me by the retiring person, and it wasn't very advanced in those days. So most of my role was developing a rota, an on-call rota, and then getting better people to take over.
I see.
So I would not claim any expertise in CBRN now.
You were the chair of the Resuscitation Council between 2009 and 2012. Is that right?
That's correct.
And you're currently the science chair of the Advanced Life Support Subcommittee of the European Resuscitation Council. Is that right?
Yes, that's correct. And that's a group that writes guidelines for advanced life support for Europe. And they're the guidelines we use in the UK.
I see. And you're the chair of the steering group of the UK Out of Hospital Cardiac Arrest Outcomes Project that studies all cardiac arrests treated by English ambulance services. Is that right?
That's correct.
You have authored over 300 scientific papers, 15 textbooks, and over 25 book chapters about anesthesia, resuscitation, and intensive care medicine. Is that right?
That's correct.
And you are the lead author for the current UK and European cardiac arrest guidelines for adult advanced life support, and the global evidence reviews supporting those guidelines. And you're the co-author of the guidelines used for prognosis in comatose patients after a cardiac arrest in the UK. Is that right?
Yes, that's correct. So the current guidelines and the guidelines that were in place in 2018, because they changed in about 2020, 2021.
I see. If we can turn then to Professor Nolan. So your expertise are set out just, yes, at the bottom of the page there. Thank you very much. You were also a medical doctor whose specialist field is anesthetic and intensive care medicine. Is that right?
That is correct.
And you have been a consultant in anesthesia and intensive care medicine at the Royal United Hospital, Bath, since 1994.
Yes, I have.
You are the immediate past chairman of the European Resuscitation Council and editor-in-chief of the Journal of Resuscitation.
That is correct.
And you chair the steering committee of the UK National Cardiac Arrest Audit, which is the National Registry of in-hospital cardiac arrests. Is that right?
That's correct.
You were in full-time practice in anesthesia until April 2023. Is that right?
That is correct.
And you remain in part-time clinical practice. I think it's 0.8 is what you set out in the report.
Approximately, that is correct, yes. About 2/3 time.
I see. You also hold academic posts as an honorary professor of resuscitation medicine in the School of Clinical Sciences at the University of Bristol and professor of resuscitation medicine at the University of Warwick.
That is correct.
Is that right? Okay. We can take the report down now, thank you. You have both been instructed to prepare these reports by the solicitor to the inquiry, Mr. Martin Smith.
That's correct.
Okay. You have been provided with quite a large volume of material to conduct your analysis, and I think we don't need to go to it, but you have recorded a list of the documents given to you at pages 8 to 14 of your first report.
Yes, that's correct.
The material includes the medical records, contemporaneous medical records in hospital and both pre-hospital for Don Sturgess, witness statements from the treating clinicians, police officers at the scene, paramedics, passers-by. You have also seen the expert report of Mark Faulkner, who gave evidence yesterday.
That's correct.
And you've seen the reports and statements of forensic pathologist Guy Rutty. Is that right?
Yes, that's correct.
Okay. You have recorded the instructions at page 6 of your report. If we could just pull that up now, please. Your instructions were to consider the symptoms of nerve agent poisoning that hospital staff treating Dawn should have been aware of, the appropriate treatment for somebody who's exhibiting symptoms of that poisoning. And then if we scroll down, please. The training that staff ought to have received on those issues, the treatment that was provided to Dawn by hospital staff, and whether that treatment was appropriate. Yes, and then if we just continue scrolling down. We'll also, you were also asked to cover the question of whether Dawn should have been treated for nerve agent poisoning sooner or an earlier stage than was the case. You were also asked to compare the treatment provided to Dawn and that to Charlie Rowley and the Skripals. And then at the bottom, we have the causation instructions. You were instructed to consider at which point Dawn's condition became unsurvivable and why that was. And related to that, whether, if there were any inadequacies in the treatment given to her, either by paramedics or hospital staff, or information passed by the police, whether any of those inadequacies would have, or failings would have contributed to her death.
That's correct.
Those are the instructions. So now I'm going to move on, if I may, to the reports. The first topic that I'd like to explore is that of an overview of organophosphate poisoning. And for this topic, Professor Nolan, I'm going to ask you the questions. And as we discussed, Dr. Soar, if you have anything to add, please do feel free to do so after Professor Nolan has answered the question. Now, turning to organophosphate poisoning, if we could pull up the first report, page 15, please. Oh, thank you very much. To begin with, Professor Nolan, what are organophosphate nerve agents?
So these are nerve agents that are chemically related to the organophosphates. They're chemically related to organophosphate pesticides and include a number of agents that I've listed on there, such as the G agents. I've listed those, I won't go into the detail, and V agents. And then importantly, it also includes a group of new agents, which are called Novichok, and Novichok means a newcomer in Russian.
Okay. And can you explain to us how organophosphates work? How do they work?
So an organophosphate will actually inhibit or block the action of the enzyme acetylcholinesterase. And forgive me for all these long names. This is an enzyme that is responsible for breaking down the substance acetylcholine. And acetylcholine itself it's a nerve transmitter, so it's found at the junctions between two nerves. It's also found in the junctions between a nerve and a muscle. It's also found in the lung, and acetylcholinesterase is also interestingly found in red blood cell membranes as well. And the purpose of acetylcholine when it functions normally is to break down that acetylcholine so that when a nerve transmission occurs, it will then break the transmission. It really allows the acetylcholine to regenerate so that it's ready for the next nerve transmission to come along. And if that process is blocked, if that acetylcholinesterase enzyme is blocked, it means there's almost a sort of continuous nerve transmission, a sort of overactivity of those nerves. And that creates this sort of so-called cholinergic state.
I see. Can I ask you to look at figure 1 on page 16? We have quite a helpful diagram there, I think, of the process that you've just described.
That's correct.
If we could just zoom in on the figure and perhaps just take it in stages. So on the left-hand side, left third, what does that show in the figure?
So the left-hand side shows the little blue top dots there that you can see of the acetylcholine, and then they go across, and so they're crossing that junction between the two nerves, and they're binding to receptors on the other side. And to add even more complexity, there are two different types of receptors, so-called nicotinic and muscarinic receptors, and they're in different locations or different parts of the body.
And here they're represented by the silver is the nicotinic receptor, and the pink is the muscarinic receptor. Is that right?
That is correct. And this, of course, it's a highly simplified diagram, although it looks, I'm sure, quite complicated.
We appreciate the simplicity, I can say.
And then the acetylcholinesterase enzyme, which we can see in the middle sector of this diagram, is seen there binding and mopping up the excess acetylcholine. And then if we move to the right-hand side part of the diagram, we can see there the sort of red blobs marked with an X. It's depicting Novichok, and that is binding with that acetylcholinesterase, so it's preventing it from breaking down the acetylcholine. And the net result of that is you have far too much acetylcholine in that nerve junction. The same, by the way, would be true of a junction between a nerve and a muscle, for example. And that causes this massive overactivity.
I see. If we look at the middle section of the diagram, we can see that the acetylcholinesterase is binding with the blue dots, which are the acetylcholine.
That's correct.
And so they're not able to attach to those receptors, and we don't have that signal.
That's great, but it also allows those blue dots then to be broken down. And what's not clearly shown, or perhaps it's shown in parts of the diagram, is that then can be sort of reaccumulated back into the top nerve, if you like, so that it's ready to be released by the next nerve.
I see.
So in that way, the whole process is controlled.
I see. And then on the right-hand side, we can see, as you said, the Novichok binding to that acetylcholine esterase, so that there's the mechanism of preventing the acetylcholine from attaching to the receptors is disrupted, and so there's a sort of continuous
That's correct.
signal. Is that right? Okay.
And the key is that potentially the Novichok is binding irreversibly to that acetylcholinesterase. Because I perhaps should highlight that we sometimes use drugs in anaesthesia that will cause a temporary block of that enzyme, which then is removed over a period of a few minutes, perhaps 30 minutes or so. The difference is with these nerve agents is that they can be potentially permanent.
I see. Well, in fact, I was going to ask you next about oximes, which is covered in page 15 of your report. If we could just go back a page. Yes, so the final paragraph. So you said organophosphate binds to the acetylcholinesterase molecules by phosphorylation.
That's correct.
And then oximes such as pralidoxime can reactivate. Will you tell us, in fact?
Yes, so oximes such as pralidoxime, and there's another one called obidoxime, can reactivate the acetylcholinesterase by removing that phosphor group. So it's a molecular group that it can remove. And then, in essence, it reactivates that acetylcholinesterase and restores nerve and muscle function back to normal. I think the key thing here is that it needs to be done relatively quickly, and it depends on what sort of nerve agent is involved. But if it's not done rapidly enough, the acetylcholinesterase becomes non-reactivatable. So in other words, the oxime cannot work. And so you have a permanent problem with deactivation of the acetylcholinesterase. And that's a term that's called aging.
I see. FT49 gave evidence to the inquiry on the 31st of October. Have you had a chance to see his evidence?
Yes, I have.
So his evidence was that with Novichok's specifically, there is early and truly irreversible inhibition of acetylcholinesterase that is almost completely unreactivable by pralidoxime. And I think he said, being colloquial, that at the point of injury with Novichok's, he said pralidoxime isn't bringing much to the party.
Yes, and that's what I understood. So in fact, it causes this aging process so rapidly that pralidoxime is not going to have an effect, or is not going to be able to reverse that process.
Thank you. I'm going to move on now to the effects in the body of acetylcholinesterase. So if we move now to page 17 of your report. Acetylcholinesterase binds to two types of receptors. Could you just explain to us, and we saw them in the diagram, in fact, the nicotinic and the muscarinic. Can you just explain to us what those different receptors are responsible for?
So it's the excess acetylcholine that is then binding to these different types of receptors. And there are broadly two types, the so-called nicotinic receptors. And they tend to be present in the central nervous system and junctions between nerves and muscles. And so the effects of overactivity of acetylcholine as a result of this acetylcholinesterase block is that you see muscle fasciculations, which are almost like fine twitching movements of the muscles.
I see.
And we do see that in anaesthesia when we administer a particular type of nerve blocking drug that causes that effect temporarily. In turn, then you can get muscle weakness, and that can be profound and total muscle weakness that builds up over a period of time. You can, and this is complex, but briefly it is possible to see high blood pressure, which is hypertension, and a fast heart rate, so-called tachycardia, which is almost the opposite of what comes along later on with this substance. That's important with some of the observations for the individual that we may be discussing later. So those are the main so-called nicotinic effects.
Can I ask, you say you might get this sort of muscle twitching. Would that be something that might be mistaken for a seizure, or is it a different kind of twitching at that
No,
stage?
it could easily be mistaken for a seizure, not just by members of the public, but even by healthcare professionals. Because unless you were, for example, an anaesthetist who is used to seeing that type of muscle activity, it would be very hard to explain other than by seizures.
I see. Just, if I may, 1 minute, Dr. Soar. I just wanted to ask just one follow-up about whether you talk about muscle weakness. Where does that come from? If you have these if you have this twitching, how does that develop into muscle weakness?
So eventually the muscle it'll become weak because it really can't get nerve transmission going through to the muscle. So your muscles then just fail to work and become progressively more weak, and paralysed would be the other term for that. And that then can last for some time. That paralysis can affect nearly all muscles in the body, but importantly, not just muscles, for example, to your arms and legs, but to the breathing muscles as well. The diaphragm, for example, can be paralysed. That will cause the person to eventually stop breathing altogether. In other words, have a respiratory arrest.
I see. Thank you. Dr. Soar.
Yeah, I was just going to add a small amount. As part of that initial twitching, you can get stiffness, and that's been described where people are very stiff, or the clenching of the teeth, trismus, where the twitching of muscles means the mouth is hard to open, and that was described in some of these cases.
Yes. Thank you. Moving on then from the nicotinic receptors to the muscarinic receptors. The effect of a buildup of acetylcholine, what would be the effect, the muscarinic receptor effect?
So these have a number of effects, and this is being produced by the so-called parasympathetic nervous system, which is part of our sort of automatic nervous system, if you like. And so we've listed them here, but meiosis, which is a constriction of the pupils, so it creates very, very tiny, small pupils that don't respond to light. That in turn can cause blurring of vision, if the person is then still conscious to complain of that, of course. And then you can get quite marked secretions, so salivation, so drooling of the mouth and secretions coming from the mouth, and rhinorrhea, which is really secretions, nasal secretions coming from the nose. It can cause profuse sweating, which is something that's been described in many of the cases. It can also cause bronchoconstriction, which is narrowing of the airways to the lungs. And then it can cause bradycardia, so a slowing of the heart rate, and then hypotension, which is a low blood pressure. And indeed, either of those things could be so severe as to actually cause the heart to stop, so to cause cardiac arrest. You also get effects on the gastrointestinal system, so the bowel can cause abdominal cramps and severe diarrhea. And it also tends to cause contraction of the bladder, so that you get uncontrollable incontinence, urination. And there are also some effects on some of the enzymes of the body that I've mentioned there, plasma lipase and amylase.
I see. If we can move on then from the effects on those two receptors, to the central nervous system symptoms and signs. So you told us a moment ago that muscarinic receptors also deal with the parasympathetic nervous system. Is that right?
That's correct,
Sort
yes.
of automatic nervous system.
That's correct.
And so are there also effects on the central nervous system?
There are, because there are, in fact, actually both nicotinic and muscarinic receptors in the central nervous system, by which we mean the brain and the spinal cord. And so the effects there can be anxiety, confusion and agitation. It can cause seizures, and the seizures that are caused with nerve agents can have multiple causes. So it could be the direct effect of the nerve agent acting on the brain to cause seizure activity. But because of the impairment of breathing, because of the gradual weakening of breathing muscles, then that could also result in very low oxygen levels in the blood and therefore low oxygen levels in the brain, which in itself could potentially cause seizures. So there's two mechanisms that they may occur.
I wonder if I could just pause you there. We've heard a lot about seizures, but could you just help us with a seizure? Is that an activity in the brain?
So a seizure occurs when there's overactivity in the brain, so electrical activity in the brain, abnormal electrical activity that causes what might be termed fitting or other types. And there are different types of seizures, but I think we're talking about generalized seizures of the body.
Okay, so there's a sort of brain, unusual electrical activity in there, and it can cause a seizure. We've heard, for example, from a passerby, Helen Ward, who saw Julia Skripal, and she describes her having a sort of clonic seizure on the bench. Not expecting you to be able to tell us exactly the mechanism behind that, but would we expect there to be sort of electrical activity in the brain which is causing these sort of unusual movements in the body and so on?
Yes, so that will come from abnormal excessive electrical activity in the brain, and there's sort of there's different types of movements that you get with that. There's the sort of typical jerking movements that perhaps other people will be familiar with so-called grand mal seizures, or you can get, as was described here, some more clonic activity, which is more jerky movements that may not involve the whole body. It may involve parts of the body. But it all, in essence, is coming from overactivity or an abnormal activity in the brain.
In the brain, I see. So you were just telling us that Novichok might act directly on the brain, causing a seizure. There might also be another way, which is that there's a lack of oxygen, which itself could cause a seizure. Is that right?
That's correct. And that lack of oxygen can come about partly because the breathing muscles are not working very well. It may be that there's excessive secretions that are blocking the airway and actually impairing oxygen getting into the lungs. Mm-hmm. It could also be that the blood pressure has become low, and that in turn also means that oxygen is not being delivered to the brain properly. And all of those things combined could result in seizures.
I see. Other central nervous system symptoms and signs that you've listed there are respiratory depression, which I think we've covered, coma and death. That comes about as a result of the depression of the central nervous system.
That's right. Again, that is multifactorial potentially, in that it could be a direct depression of the central nervous system by the nerve agent. But it could also be because of the breathing muscles not working properly, so breathing or respiratory failure, or it could be because of very low blood pressure. But the net result would be reducing conscious level for that person until they become completely unconscious. In other words, they don't respond to a painful stimulus, for example, and therefore are, by definition, in a coma.
Mm-hmm. We have heard evidence, for example, of Yulia and Sergei Skripal on the bench being in a non-responsive state, but still being breathing. So would that suggest that the effects on the central nervous system could be altered levels of consciousness even when the person is still breathing?
Yes, absolutely. It is possible. Well, it's possible to be comatose, completely unconscious, and still be breathing. And there are sort of variations along that sort of spectrum. But certainly it would appear that they were still breathing and yet unresponsive at that stage.
Mm-hmm. Finally, you've listed hypothermia as an effect.
Yes, this is something which has been reported, and the individuals that we will be discussing today, to a variable extent, were impacted by this as well. So they had low body temperatures, which is what hypothermia is. Again, there's potentially a number of mechanisms for that, but it's thought that there may be a direct effect on the temperature control mechanisms in the brain coming from the nerve agents itself. It's also possible with excessive sweating, for example, to lose quite a lot of heat. That can bring the body temperature down.
I see.
And I should add, and importantly, if somebody has a cardiac arrest, if their heart stops and they're resuscitated, these individuals will also have a potentially low body temperature to start with as well. So again, there's multiple facets to that.
I see. If we can scroll down to page 18. Oh, there we go. Yes, just at the bottom of the page there, you point out that several features of organophosphorus nerve agent poisoning overlap with those of opioid overdose. Can you just tell us a bit more about that?
Yes, and I think this is a very important point of discussion in these particular cases because of the confusion that occurred. But an opioid overdose, and an opioid is any substance related to morphine, so it would include morphine itself, it could include fentanyl and a number of other opiate drugs. But they will cause in overdose pupillary constriction, so meiosis. They will certainly depress the breathing to the point that they could easily cause respiratory arrest. They could stop the breathing completely. They can reduce somebody's conscious level, even to the point of them being comatose, deeply unconscious. And they can indeed slow heart rate as well. I should add, although that's not there, that you could see seizures as a result of opiate overdoses because of the mechanisms we've already discussed, in that if the breathing is depressed, the oxygen levels can go very low, and that could cause seizure activities. The two things that are not typical of an opioid overdose are lots of an excessive secretions. So we talked about secretions from the nose and from the mouth. And sweating is also not typical of an opioid overdose. And so that's why there's been the suggestion that perhaps we should refer to organophosphorus poisoning as perhaps the wet opioid toxidrome. In other words, all the features of an opioid toxidrome, or collection of features, but with the wet component because of these secretions and sweating.
Mm-hmm.
I follow that as the typical case, Professor Nolan. Did you hear Mr. Faulkner's?
I did, sir, and I read very carefully what Mr. Faulkner was saying, and please correct me if I'm wrong, but I believe he commented that he has seen cases of opioid overdoses.
Get some pretty wet
getting
overdoses, he said.
Yes, that's right.
I think, and certainly I think that's possible. It's not something we would see as a feature of opioid overdose. Both Dr. Saw and myself will be using a lot of opioids giving to patients over a number of years, and sometimes in high doses, and it's not something that we would see in that setting. It is entirely possible that one could see secretions, perhaps mistaken for regurgitated fluid, for example, if somebody's deeply unconscious. And in some cases, clearly if patients go on to have a cardiac arrest as a result of opioids, they can get fluid in their lungs or pulmonary edema, which can emerge from the mouth as well. So it's certainly understandable that there could be confusion, but I don't think that excessive secretions are classically directly caused by an opiate overdose itself.
Yes.
Right.
Sorry.
I'd like to. We did discuss this, and I think Professor Nolan and I had worked out that between us we'd given opioids to over 30,000 patients, and often in very high doses, so fentanyl, morphine, but in very controlled circumstances because they're commonly used in anaesthesia, critical care, and it's not a feature we recognise. The issue is that we're using the real medicinal product in a controlled circumstance. And when patients take opioid overdoses in the community settings, it's never quite just opioid. It could be opioid and something else. So you never see that clean clinical presentation that we would see in a controlled clinical setting where we've opened a bottle that says fentanyl on it and it is fentanyl.
Yes, I see.
Thank you.
Just to pick up on one aspect of your response, Professor Nolan, you talked about secretions being common, I think, in post-cardiac arrest. Is that right?
They can be because, well, for a number of reasons. So after cardiac arrest, it's possible to have regurgitation of stomach contents that could be mistaken for secretions. It's also not unusual, particularly in a prolonged cardiac arrest and resuscitation attempt, to see what's called pulmonary edema, where there's excessive fluid building up in the lungs. And that then can emerge from the mouth and certainly would be very hard to distinguish between secretions that had originated from the mouth, as it were, rather than lower down in the lungs.
We heard evidence from the paramedics who treated Dawn, and she had a lot of secretions in her mouth. They were coming up the eye gel, the airway that the paramedics had inserted. And in their evidence, they were asked about whether they thought those secretions were unusual. And the evidence certainly of Mr. Coomer, the paramedic, was that that's something that wasn't unusual in somebody who had a resumption of spontaneous circulation. So you would agree with him?
I would entirely agree with that. I think that's that could easily be explained by that process rather than anything else.
I see. And the sweating, would sweating be something that you would expect in a post-cardiac arrest patient?
No, it's not something you would typically see in a post-cardiac arrest patient. As I say, the body temperature can be low. That's certainly something that you would see, but sweating would not be typical of a post-cardiac arrest patient.
I see. Moving on then from the overlap with opioid overdose, going to ask you briefly, Professor Nolan, about decontamination. So if we move to page 19 of your report, an important aspect of treatment for such an overdose would include decontamination, which would be removal of the clothing of a victim because the fibers can trap liquid nerve agents and vapor.
That's correct.
And the National Poisons Information Service provides detailed guidance, which you've appended at Appendix 1 of the report. We don't need to go to that. And in your report, you also note that DSTL documents that absorption of Novichok through the skin is probably rapid. Within 15 minutes, all liquid chemical will be absorbed, and the bulk within 3 minutes.
That is what I've understood, and we've taken that from a presentation that was made by the Defence Science and Technology Laboratory. I should emphasise this is clearly outside the expertise of Dr. Saw and myself, so that is something we're relying on that information.
Yes.
It's important because it implies that Novichok specifically is potentially absorbed very rapidly through the skin. And it's very what's called lipid soluble, so it dissolves very easily in fat, so we understand, and that may be part of that reason.
Yes, FT49 in his evidence described it as being lipid soluble. Well then, if we can move on to what is, I think, firmly within your expertise, and that is treatment.
Otto, are you going to come back? I expect you are, to the time factor, because we heard evidence about the gap between we heard evidence about the time lapse before symptoms appeared in some cases. You're coming back to that?
Yes, we will be dealing with that.
Thank you.
Yes. So then moving on to treatment, which you've set out at page 19 of your report. So can you just give us could you give us an explanation of the kind of treatment that would be appropriate for nerve agent poisoning?
Yes, so I think there are sort of general treatments and specific treatments. So what's bulleted first there is to ensure safety of the individuals who are treating the individual, so hence the donning of personal protection. And then importantly is to consider, I guess, what we would call in any resuscitation the ABCs. So ensuring that a person's airway is clear and that they're getting sufficient oxygen, because if they don't have if the airway is obstructed and they're not getting oxygen, they will die very quickly from that. And then there is also attention to circulation and blood pressure. We've listed there the importance of removing clothing, which is part of that decontamination, and then establishing intravenous access.
Yes. You've also mentioned, if we move over to page 20 of your report, you've described there that if a patient develops increased secretions, that it is important to give atropine urgently. Is that right?
That's correct. So atropine is an anti-muscarinic drug, so that will counteract the effects of this excess acetylcholine in the parasympathetic system, and will help then to dry up secretions. Importantly also, if the heart rate is very slow, particularly if it's associated with a low blood pressure, then the atropine will tend to increase the heart rate and potentially increase the blood pressure as well. So that's the importance of giving the atropine. So it's really treating symptoms more than anything else. And then so that's one specific treatment as opposed to a general treatment. Another specific treatment is to give an oxime, so typically in this country, pralidoxime. And the recommendation is to give that once atropinization has been achieved. And I should explain what atropinization means. I think it's seeing a response to that atropine, particularly seeing the heart rate increase appropriately and the blood pressure be increased, I think, above 80 millimeters of mercury.
I see.
This, and I have to say, maybe that will be asked, but it does seem to slightly contradict what we're learning from FT49 about the impact that pralidoxime can have. But nonetheless, that is the guidance at the moment, to give pralidoxime.
Yes. You also discuss anticonvulsant drugs there, I think.
Yes, so that's really, I guess, the third arm is to treat any seizures with anticonvulsant drugs. A common drug, and there are many possibilities, but a common one, and certainly one that's available pre-hospital by the ambulance service, would be a drug called diazepam. Used to be called Valium by trade name. And there are others that we've listed there, lorazepam or midazolam. They're all benzodiazepine groups of drugs, and they will control seizures. But there are other drugs as well that will do that, and most importantly, the drug propofol, which is actually an anaesthetic drug. It's used very commonly as sedation in intensive care. That is also a very powerful anticonvulsant.
I see. And can you help us with this? In terms of preventing the seizures, is that would prevent the physical manifestation in the body, if I can put it that way? Will that also protect the brain from that electrical activity that you told us about?
So that's a good. So it is possible to have seizure activity in the brain without it being manifest as obvious jerking movements or even at all visible. Mm-hmm. And that's called non-convulsive status epilepticus. So that, in other words, non-convulsive, you're still getting seizure activity, but none of the convulsions with it. It's certainly possible to have that, and it could theoretically be more possible here if there's been paralysis of muscles, because if the muscles don't move, they won't actually have seizure activity in response to what's going on in the brain.
And so if you give these anticonvulsant drugs, will they, well, I suppose I should start one step back. The electrical activity that you have in the brain during a seizure, is that harmful to the brain in any way?
It is generally thought to be.
Okay.
I'm choosing my words carefully because the absolute evidence for that is not completely clear, but that I think that it is generally accepted that continued seizure activity in the brain may of itself be harmful. But as I say, we're not 100% sure of that.
Okay. And by giving anticonvulsant drugs, will that prevent that electrical activity in the brain or no?
Well, if the seizures were visible and you can see that the seizures stop when you give an anticonvulsant drug, then it may be reasonable to assume that you have stopped the seizures in the brain. However, if you can't see visible signs of seizure activity, it's very difficult to know whether you've stopped those seizures unless you use brainwave monitoring, or EEG, for example,
Like
to actually look at the activity in the brain. And that's something that would only be done, well, obviously, in hospital.
Yes, I see. Thank you. Dr. Sawyer.
Yeah, so I was going to just add a point just to emphasise. So seizures can cause brain injury, but if the brain's already injured, it can express that as seizures. So even if you stop them, it doesn't necessarily mean you've reversed the brain injury. So it can be a part of the brain getting injured, or the brain's already injured, and it's probably the point you intervene at, whether you prevent brain injury.
I see. So a seizure could be both a cause and a symptom of a brain
Yes.
injury. Okay. Thank you. Before we move on from the specific treatment, at page 20, you talk about the need to undertake tracheal intubation. We've seen that quite a bit in the evidence already. The need to check arterial blood gases. Can you just tell us a little bit about that? What arterial blood gases would show?
Yes, so an arterial blood gas is where you take a sample of blood from an artery, specifically, rather than a vein, and it's a point of care test, so it's a test that can be done at the patient's side, and we can get the results very rapidly. And it gives a lot of information. It gives information about the oxygen levels in the blood, an accurate measure of that. It gives information about the adequacy of ventilation, so how well that person is breathing, if they're under breathing, or if the breathing's being done for them, if they're being underventilated, then carbon dioxide levels will be high, for example. It gives us an indication of the acidity in the blood, which can be an important marker for whether somebody's in shock, for example, whether the cells of the body are getting sufficient oxygen. Because if somebody's in shock, the cells of the body are not getting enough oxygen, the blood tends to become progressively more acidic.
We've heard that when Dawn Sturgess arrived in the intensive care unit, her blood was quite acidic. Is that something that could be rectified by changing the ventilator settings, for example, to increase the oxygen flow? So
it depends, because broadly there are two mechanisms for increasing acidity in the blood. One could be because of insufficient breathing, insufficient ventilation, and as you've suggested, turning the ventilator up, increasing the amount of ventilation of the lungs, could certainly help to bring that acidity more towards normal. A more common thing is, though, that it reflects the sort of metabolic processes in the body and may reflect, as I say, a lack of oxygen generally getting to the blood cells. And that may require more sophisticated resuscitation. It may require more fluid to try and get more blood and oxygen to the cells. It may require the use of drugs to improve the blood pressure and or the pumping of the heart, for example,
I see.
to get more blood and oxygen around to those blood cells. So there are a number of sort of facets to the treatment of that.
I see. Thank you.
Are you leaving the treatment advice for the moment, at least, Ms. Pottle? Are you leaving the treatment advice, at least for the moment, or not?
Well, I was just going to take Professor Nolan to the, I think, quite helpful guidance that was in place at the time.
Yes, by all means.
Yes.
In that case, I'll wait.
So if we turn Appendix 4 and 5 to your report, if we turn to page 130. Thank you very much. So this is Appendix 4 is the guidance in place at the time that Dawn was treated. So it's the management of organophosphate nerve agent poisoning, which is reproduced from the chemical, biological, radiological, and nuclear incidents. I suppose that's a handbook prepared by Public Health England. It's dated the 31st of May of 2018. And it sets out here a sort of précis of the management of cases of suspected organophosphate nerve agent poisoning. Is that right?
That's correct,
That's
yes.
what we're looking at here, yes. The management is as you've set out in your report, and we can see underneath here, atropine, dosage information is given. And there's a reference here to doses to be repeated every 5 minutes until the patient is atropinized, which
That's correct, yes. So there's a number of, so heart rate, which I guess is perhaps the main target, where if the heart rate has been very slow, one is aiming to give sufficient atropine to raise that heart rate to 80 beats per minute or more. In this particular guidance, and I should say these vary slightly depending on which year you're in, but for this particular one, it just says the blood pressure is adequate, without necessarily saying what that blood pressure is.
yes,
But that's probably because it's very difficult to give a very specific blood pressure. But
Well,
obviously,
sorry, I was going to say we've heard from Dr. Jukes that when somebody has had a cardiac arrest, which I appreciate is not, well, hopefully most people who will need this sort of treatment, there's a danger of overworking the heart by having the heart beat too quickly, for example. So I suppose this guidance might accommodate different blood pressures or different heart rates depending on the patient's situation. Do you think that's right?
yes, that's absolutely correct, and indeed very important, because it may be that a heart rate, and I think we do mention this elsewhere in the report, that a heart rate that's relatively slow, as long as the blood pressure is adequate, I'll use that word, may be the best thing for the heart, because increasing the heart rate, particularly, and I should add, if the body is cold as well, hypothermic, then it may be entirely appropriate and optimal for that heart rate to be relatively slow. And for the reason for that, for technical reasons, it actually improves blood and oxygen delivery to the heart muscle itself. A fast heart rate can actually cause the heart muscle to overwork, perhaps in the face of an inadequate oxygen supply, and can cause problems itself.
I see.
So this guidance is a broad guidance to cover a very broad range of patients, but specifically in the post-cardiac arrest setting, that figure may be rather high, the figure of 80 beats per minute.
I see, okay. And we have then, just very quickly, pralidoxime, which we've discussed already, is another, on the next page, we set out doses for pralidoxime, and then finally for benzodiazepines for the control of convulsions.
Yes, that's correct.
So we had discussed that. I think Appendix 5, we don't need to pull it up, but that is the talk space advice on the management of Novichok poisoning. Just to clarify, that wasn't in place at the time that Dawn...
That's correct. So that's the current one as of April 2022,
Yes.
and goes into a lot more detail.
Yes.
I mean, I should add that clinicians, whether they be emergency doctors and nurses or intensive care doctors and nurses, under these sorts of circumstances where there's been any form of poisoning, would typically contact the National Poisons Information Service, which is TOCSpace,
Yes.
to get all this information.
They wouldn't necessarily know it off the top of their heads.
No, that's what I'm getting at.
Yes.
So even somebody who's really pretty experienced, myself and Dr. Saw, for example, would be going to ToxBase to get this information. I guess it's because it may not be something you see very often. Clearly, nerve agent is extremely rare, but even in other poisonings, you may not see them very often. The recommendations may change over time, and I think it's important that you get this sort of up-to-date advice for whatever poison it is.
Yes, I see. So that's a bit of a broader point, which is that perhaps unlike more common conditions, when it comes to a very unusual condition such as this, you wouldn't expect a physician to necessarily know off the top of their head the exact dosage or treatment, and you would expect a reasonable physician to make contact with an appropriate authority such as ToxBase to find
Definitely,
out
yes.
what
Yes.
was required. Okay, well, that's very helpful. Thank you. Now, so that was the end of the.
Well, it's a very small point, Professor Nolan. Can we just go back to page 130, please? Because you were looking at it just now. This is the standard advice prevailing at the time for the management of organophosphate nerve agent poisoning. Right?
That's correct, sir, yes.
And as you rightly pointed out, at the 1, 2, 3, 4, 5, 6th bullet point down, it advises give pralidoxin.
It does indeed, sir.
You
yes.
mentioned the fact that FT49 had told us that pralidoxin isn't terribly effective, at least with Novichok's. Have I got it right? Because the point about Novichok's is that they make the inhibition of the acetylcholinesterase irreversible too quickly.
That's absolutely correct, sir.
Yeah, but this advice, is this specific to Novichok's, or is this for general organophosphate?
No, that's a very good point. It is organophosphates in general, so that there could well be others that pralidoxin would have an effect on. The other thing, just to say, and it may come up later, is and the FT49, I think, made these comments. It's just possible that pralidoxin has some other effects, beneficial effects that are subtle. For example, in the central nervous system in the brain. So where it perhaps is not necessarily reversing, if you like, the acetylcholinesterase block, but may have some other function. That is definitely beyond my expertise, but I think it's important to say that we're unsure, and it could have other benefits.
It could be useful treatment, even if in the end it's not going to be very effective in the Novichok cases.
That's correct, sir.
Okay.
Yes.
And the other thing as a broad principle is I'm not seeing in the literature much in the way of harmful effects. And one always, when there's uncertainty about a treatment, one could argue that if there's no significant harm from the treatment and there may be benefit, then it might be reasonable to give it.
Yes. To complete the circle, I think the presentation prepared by FT49 and Dr. Haslam does talk about off-target effects for pralidoxin and it having an unexpected effect on muscarinic receptors. But, sir, it's an important point that this guidance does extend beyond simply Novichok in any event. In fact, I said I was going to move on from treatment, but there's one more thing that I wanted to ask you about, Professor Nolan, and that is we've heard a lot about auto-injectors, and I think you deal with that at page 22 of your report. There's no need to pull it up, but just for your reference, Professor, it is page 22. Can you just help us with what an auto-injector is and what it contains?
So, well, an auto-injector is a sort of generic syringe-like device that would enable the easy injection of a number of substances. So they're used in lots of settings with lots of different drugs. Yes. But specifically for this case, I think the one that is mentioned here is duodote, which is so that's contained in it's actually a 2-compartment syringe, but it enables somebody easily to give an intramuscular, so an injection into the muscle of, in this particular case, a combination of atropine and pralidoxin. So those two specific treatments can be administered together quite quickly into a muscle.
Yes.
And that can be, I understand, I'm not a pre-hospital expert, but I understand those are carried by the ambulance services today.
Yes. And then you also mentioned in your report a combo pen.
Yes, so that I mentioned that because it's actually listed in the ToxBase guidance.
Yes.
I'm not clear whether any or all of the ambulance services carry that particular one, but it's a similar concept. There's slightly different doses, but it's a combination of atropine and pralidoxime. But it also has another drug, which is a sort of what's called a prodrug. In other words, when it's put into the body, it's broken down into, in this case, diazomols, which is an anticonvulsant drug. So it's almost a single injection with a three-pronged attack on the nerve agent.
I see. I'd like to ask you now about a figure which appears at page 24 of your report. It is, I believe, a figure that is reproduced from the Lancet Medical Journal, is that right?
That is correct. It's from a case report that was published in the Lancet in 2021.
And it is anonymized, of course, but it is a confirmed poisoning in 2020 of a 44-year-old male who became ill on a flight in Russia and presented to a local hospital in a coma with excess salivation and sweating. And it was a confirmed case of Novichok poisoning.
That is correct.
Confirmed by the Organization for the Prohibition of Chemical Weapons. Now, the reason I'm asking you about this is not to talk about the responsibility for that poisoning, but I believe, and please correct me if I'm wrong, that you have referred to it in your report as a helpful illustration of the treatment of somebody with Novichok in another country, and that it's possible to gain some insights into their clinical course.
Yes, that's absolutely correct. I think many of us felt it's actually quite remarkable detail provided in this case report in terms of various tests that were done, the treatment that was given to this individual, and in some ways it's been helpful in the interpretation of some of the testing that was done in the particular cases we're discussing today.
So if we can pull up the figure, please. It's page 24 of the report. Yeah, and perhaps if we could just zoom in. Yes, thank you very much. So we can see at the top of the page a very helpful graphic, I think. It gives us the days that the patient was receiving treatment, I suppose.
Yes, indeed.
And along the left-hand side, we can see there is a representation for different categories of treatment. So ventilation, for example, we can see the patient received continuous ventilation in the beginning. And as his treatment progressed, will you tell us?
Yes, so we can see depicted there continuous ventilation. In other words, this individual was receiving mechanical ventilation or from a breathing machine for a number of days. Typically what happens is then as the breathing starts to improve, the machine will give assistance to each breath until eventually one is able to breathe completely. And spontaneous breathing is essentially when somebody is breathing for themselves.
I see. Pyrexia, what is that?
So pyrexia is fever, so a high temperature. And in this case, the most likely cause of that is likely to be infection. It's very common for any person that is on a breathing machine for any length of time. It's quite common to develop infections, particularly in the lungs. So, and that would cause a fever. So that's I can't be sure, but that's a likely cause of that.
Comes with the ventilation, does it? With the artificial ventilation?
As intensive care clinicians, we hope it doesn't, sir.
No, but it can do.
We do our best to stop it, but yes, it does happen quite commonly.
When people become unconscious, it's quite common for some saliva or secretions to end up in their lungs. So about 2/3 of all people who come in to hospital unconscious and end up on a ventilator end up with a pneumonia and that's treated with antibiotics. And I think this happened in this case and some of the other cases. And normally, it's not determinant of the outcome in that if the rest of the patient gets better, the antibiotics make the lungs better.
I see, thank you. And if we move on now to myoclonus, I think is that the right word?
Yes, so it appears there were many days of myoclonus. Myoclonus are these jerking movements of the body, which almost certainly would have been related to Novichok in the absence of any other explanation. Mm-hmm. And that seems to have then settled down after perhaps about 2 weeks or so. This individual was given atropine, which is the one below that. And then, I'm struggling to see the one of that.
Antibiotics.
Oh, antibiotics, yeah. So antibiotics, obviously, for the infection.
Yes. And we can see underneath butyryl cholinesterase. So that's a level of, well, you tell us. What is
Yes,
butyryl
I'll do my
cholinesterase?
best to explain this without causing confusion. So butyryl cholinesterase is also known as pseudocholinesterase, in fact that's the term I normally use, is present in the plasma. So it's related to acetylcholinesterase, but it's different. It's in plasma and it's made by the liver. It's there because it will actually break down some drugs that we use. It is also blocked by the Novichok as well as acetylcholinesterase, and it's relatively easy to measure in the blood. So what we can see depicted on that graph is the recovery of those butyl cholinesterase levels over time. It's generally thought that as the liver can make butyl cholinesterase, it will recover at about 7% per day. The other thing is, and that's the dot on the thing, is that this individual was actually given plasma. He was transfused plasma in an attempt to bring these levels up. And what the clinicians who were treating were able to show was that they transfused this cholinesterase. It didn't make any difference to the ability of this individual to move or recover clinically, but they were able to show that the butyryl cholinesterase stayed raised and continued to climb. The implications for that were that the Novichok was not having an effect anymore, because if they'd given the plasma, they would have been able to show an increase as it had been transfused. If the Novichok was still active, then those levels would have gone right back down again.
Because the Novichok would have bound.
Exactly, it would have bound what was transfused.
I see.
So that was helpful. The other thing it's helpful for is it is showing that the Novichok effect is wearing off and that the cholinesterase is recovering. I'm using that word carefully. It implies that the acetylcholinesterase is also recovering. That can be measured in red blood cell membranes. For some reason, as we were discussing before, they have not depicted that on this chart. But you can measure red cell acetylcholinesterase, which also will recover, but much more slowly. And the problem with that is that you have to generate more new red blood cells to be able to have that acetylcholinesterase in your blood. And so that only recovers at about 1% per day.
I see.
Meanwhile, we don't know exactly what's going on in the junctions between the nerves, which is the bit we're really interested in, and indeed the junctions between the nerves and the muscles. It implies, of course, that it is recovering there as well. But what it means is that you don't need to return to completely normal levels of either the red cell acetylcholinesterase or the plasma butyl cholinesterase before that person makes a clinical recovery. And we do know from this particular case in the Lancet that this individual could be weaned from ventilation. In other words, he could breathe completely by himself, even when these butyryl cholinesterase levels were only at about 30% of normal.
Would I be correct in saying that what you can gain from this graph is knowledge that a person can have a recovery of their essential functions like breathing, for example, without having a complete return to the previous levels of acetylcholinesterase?
Yes, absolutely, as measured in red cell acetylcholinesterase. Yes, because presumably the levels in the junctions of the nerves, the nerve synapses, and at the neuromuscular junction have recovered sufficiently to get better. And it implies that if one can support the body with organ support, with a breathing machine, with drugs to help the heart if necessary, and all the other things that we do, dare I say, routinely in intensive care, then somebody should be able to recover from this as long as they have not sustained brain damage or injury as a result, for example, of a cardiac arrest, for example.
Mm-hmm. So for somebody who doesn't have that complication of a cardiac arrest and a brain injury, if you can keep their body alive in an intensive care unit with ventilators, for example, or dialysis, then their body should be able to create that acetylcholinesterase naturally. You said at a rate of 1% per day, so it's quite a slow process.
Yes, that was of one particular type. But yes, in principle, clearly the acetylcholinesterase is recovering. That, for want of a better word, the block is wearing off, and it's a matter of good in quality intensive care to maintain organ support, the various vital organs of the body, until that person recovers, as was done for these cases by our colleagues in Salisbury.
Thank you very much. That brings to an end one topic of conversation, of evidence. If I think now is probably...
Well, it's fascinating, but also very demanding for those who have to take a note of it.
Yes.
So 11:30, please. Keep your counsel in the meantime.
Thank you, sir.
Yes.
Yes. Now we're going to move on from the treatment and effects of Novichok poisoning, and we're going to move on to the cause of Don Sturgess's death. And so I'm now going to direct my questions to you, Dr. Sword, if I may.
Thank you.
In summary, the cause of Don's death was a hypoxic ischemic brain injury, which was caused by cardiorespiratory arrest, which itself was caused by nerve agent poisoning. Is that right?
That's correct.
Okay. Now, we know that Don was the only victim of the poisonings who had a cardiac arrest. And in your report, you explain that Don was probably exposed to a relatively large dose of Novichok compared with the Skripals and Charlie Rowley. And if I can ask you just to turn to page 96 of the report, and if we could bring that up on the screen. It's reference 5994, page 96. Yes, thank you. So you say that Don was probably exposed to a relatively large dose, and you make a number of observations there in your report about your conclusions about her having a large dose. Can you just take us through those?
Yes, firstly, according to the interviews with Chris Rowley, Dawn Sturgess sprayed the perfume, which we later found out is Novichok, onto her wrists, whereas he spilt it on his hands, found the smell and feel unpleasant, and immediately washed his hands with soap and water. So that, unfortunately, she unwittingly applied it in a deliberate manner. Yes. And sprayed it on herself, on her wrists. And so, as opposed to had accidental or more touch-type contact with it. And Charlie Rowley rapidly washed his hands. We've heard previously from Professor Nolan in the lectures that were given that the Novichok substance is mainly absorbed within 3 minutes and almost certainly within 15 minutes. So Charlie Rowley was able to mitigate it by washing his hands and wiping them on his jeans and so on. It does mention that he was able to smell it, which means that there must have been some aerosol that both himself and Dawn Sturgess probably inhaled. And I don't think we comment on that much, but I've heard the evidence of FT49, and inhalation was a probable route in Dawn Sturgess as well. And as anaesthetist intensivist, we use the inhalational route to give quite a lot of drugs for anesthesia and so on, and it's because it's a very effective method of getting a drug into the body, in that each breath will get a drug into the bloodstream. So if you had my lungs and laid out all the air spaces, it'd be about the size of a tennis court. It's quite a large surface area, and it's all quite well perfused with blood. So anything that gets into the lungs that's lipid soluble, which we know Novichok is, will rapidly cross from the little air spaces into the lungs, into the bloodstream, and then the lungs have a very rich blood supply, and that blood would then be pumped to the rest of the body. So that's one route, and the other route is the fact that she sprayed these doses deliberately onto her forearms or wrists, which would be, the other mechanism, which would be penetrating and permeating through the skin. Yes. And I think that's a slower mechanism than breathing it in, but it's there, as opposed to if you breathe it in from the atmosphere. If you walk away from that location, you may not, hit, or it'll fall to the ground. So there were 2 routes, and from the timeline, and again, this is based on Charlie Rowley's interviews. His recall is that was sometime between about 9:30 and 10 a.m. and that Miss Sturgess became unwell around 10 to 10:15. The ambulance call was at 10:14, so it was quite a rapid deterioration.
Yes.
And all those issues point towards probably a larger dose of the Novichok, or a more rapid route of exposure.
Yes. And I think you say in the report that Dawn Sturgess's rapid deterioration also suggests that she was smaller in size, and we heard some evidence about that already from the other experts. So a large dose, her being smaller in size, you would expect, therefore, quite a serious effect for somebody who's smaller in size. Is that right?
Yes, and clearly I don't know the weights of the other individuals who were poisoned, but I do know her weight was about 53 kilos, which, according to her GP records, which is about 8 stone, I think, 7 or 8 stone.
Yes.
In old money, so larger people tend to need larger doses of drugs or things to have an effect. It's not linear, but in general, when we have larger patients, they need more than smaller people. So that would be a possible predisposing factor.
Yes. And so then if we can turn to the impact that the Novichok had on Dawn's breathing in particular, we don't need to pull it up, but for your reference, Dr. Swartz, it dealt with that paragraph 98.
Sorry, can you say that again?
I'm asking about the impact that the dose would have on
No,
Dawn's
on the
breathing.
page.
Oh,
No,
I said paragraph 98, but it might actually be page 98. Pardon me.
Okay, yeah, okay. So in Dawn Sturgess' case, again, we've heard from Charlie Rowley's interviews that she went to the bedroom or the bathroom, and that he found in the bath, no water in the bath, probably with her clothes on, and she was, I think he described her as being sort of unresponsive and looking unwell and having seizures or breathing difficulty. And the timeline of his call suggests he called an ambulance at about 10:14 that morning.
Yes.
And I have, since writing this report, actually heard the call as well as the timings, and he describes that she's continuously fitting, and in the background of the call while he's talking, you can hear her with quite noisy breathing.
I see.
And that then gradually gets slower and slower to the point it stops at about 10:20. And the call handler uses, and I think Mr. Faulkner spoke about this, uses a predetermined script called AMPDS, where depending on the answer the person gives, it tells them what to ask, and they try to get to the right diagnosis very quickly.
Yes.
But they tend to be much slower than, so the point at which cardiac arrest was diagnosed was probably minutes or several minutes after when cardiac arrest actually occurred.
Yes.
And Professor Nolan and I have read the transcript, we've heard the tape of the call, and we feel that Dawn Sturgess was probably in cardiac arrest by about 10:20, 10:21, and it took another minute or two for the call handler to get to that answer based on the question and answering.
I see. Thank you. That's very helpful. And just to, pardon me, it's my fault because I gave you the wrong reference. But just to complete the evidence about what would have happened to her breathing. Sorry, it's page 97, paragraph 18.
Okay.
You
yes.
say that she would have stopped breathing due to a combination of the harmful effects of Novichok, including a decrease in her conscious levels, seizures, the muscle weakness, which we heard about from Professor Nolan, and a buildup of secretion in the lungs, throat, mouth, bronchospasm, and airway obstruction. And you say once breathing becomes impaired or stops, blood oxygen levels decrease. So is that right?
Yes, that's correct. So all those effects of Novichok or nerve agents that Professor Nolan described, in combination, if not rapidly treated, lead to this vicious circle of the muscles getting weaker. If you can't, and you rely on the muscles of your chest and your diaphragm to breathe, and if you can't breathe, your blood oxygen levels fall. If your brain oxygen levels fall, you lose consciousness, and your brain also controls breathing. So adding all those things together means the person becomes unconscious and not breathing. And then as the oxygen levels fall further, the heart becomes starved of oxygen and stops beating. And
Yes.
so breathing stopping is respiratory arrest. The heart stopping beating is cardiac arrest.
Yes. And so that lack of oxygen will cause her heartbeat to weaken
Yeah.
and eventually stop.
Yeah.
Is that right?
Yeah, so in terms of cardiac arrest, the sort of cardiac arrest people most commonly talk about is the time where someone may be running for a train or suddenly collapses, and that's called a primary cardiac arrest because the heart stopped first, and that's normally the sort of heart cardiac arrest where you can use a defibrillator to restart the heart. Whereas in Dawn Sturgess' case, her cardiac arrest was secondary to the breathing problem, so occurred downstream of the breathing stopping. And we know from both human observation and data of experimental laboratory studies that this process takes between 3 and 11 minutes, but that's starting with a normal oxygen level. But in Dawn's case, because her oxygen levels had already been quite low, at the point she stopped breathing, her heart stopping would have been relatively quick, within a minute or two after that.
So you think that within a minute or two of her breathing stopping, her heart would have stopped as well?
Yeah, and the precise moment when the heart stops beating isn't important. It becomes, because as the heart gets starved of oxygen, it'll just beat weaker and weaker and weaker and slower, and to the point where it's barely beating, the heart's barely beating, to the point where that's still cardiac arrest in effect. You know, there may be some movement of the heart, but it's not pumping blood effectively to the vital organs. So unless you have monitoring on the patient, you won't know the exact point in time.
I see.
But Professor Nolan and I, we've reviewed the evidence, including listening to the transcripts, and we feel that Dawn Sturgess had reached that stage around 10:20.
10:20, I see.
Yeah.
We've talked about the effect of the Novichok on her breathing and then her heart. Following on from her we could say, couldn't we, that by 10:20 she had cardiorespiratory arrest because she wasn't breathing and her heart had stopped beating. Is
Yes,
that right?
that's correct.
Yes, okay. So what was the effect of that cardiorespiratory arrest on her brain?
So, and this is something that, so the brain gets damaged by two processes. One is a lack of oxygen, which is hypoxia, or where the hypoxic comes from. And then we've been more specific than Professor Rutty, who's not used the term ischemia. And ischemia is the lack of blood flow. And when your heart stops beating, you have a loss of blood flow to the brain. And it's that combination that is a potent combination for brain damage or brain injury. And paradoxically, at the moment the heart stops beating, not a lot happens. The brain just sits there and is being starved of oxygen and is dying very slowly. And we know in Dawn Sturgess's case, Charlie Rowley did some chest compressions, but we don't know how many and how effective they were. And they may have got a little bit of blood flow. And then we know from the tape ends at about 10:29 that we've heard, and we know by 10:29 she's still not had any CPR done. So we know there's about 8 or 9 minutes on, and it's not clear from the written notes, but when you listen to the tape recording, there is no CPR until sometime after that tape ends, and that tape ends at about 10:29, and you can hear the paramedic arriving.
I see.
You see, so we know that she had about 8 or 9 minutes of no treatment for her cardiac arrest. And that's quite important because during that time, once cardiac arrest occurs, your chances of survival are fairly minimal. But by about 9 minutes with no CPR, you're getting to, vanishingly small chances of survival. So once CPR was started, it took another, 25 minutes or so for the heart to be restarted according to what time point is used. And it's during that process of restarting the heart and the heart being restarted and then over days that the processes of brain dying occur. And it's something, I was at a lecture the other day by probably the top scientist on this in the world, and he described it as it's a bit like having a nuclear reactor that shuts down, but then when you power it up, it sort of goes all haywire, and all these reactions start causing damage, and the reason is that all those processes of the brain dying require energy, and by restarting the heart and restarting blood flow to the brain, you switch on all these processes that make the brain swell up and the cells start to die. And at the moment, there are no specific treatments that we have to reverse that process.
I see.
And that's why with successive scans, the brain looked worse. The initial scan showed some evidence of early hypoxic ischemic brain injury, and the scan on day 6 showed much worse injury, and so on.
Before we go on to discuss the brain scans, can I ask, in your report you say that the severity of the brain damage is worse when the arrest occurs following breathing stopping than if there was a prime cardiac reason. Can you just explain that to us?
So the classic primary cardiac arrest is the person running for the train and their heart stops. And they start with a normal oxygen level in their brain. So, and if someone witnesses that arrest and starts CPR and restarts the heart, it's often restarted before the brain's been fully starved of oxygen.
I see.
Whereas when the breathing stops first, the oxygen levels fall to very low, and the process of brain injury has already started. And then if you then add in the heartbeat stopping and no blood flow, that combination is far more potent at causing a brain injury.
I see.
So that causes a much more severe brain injury when it's caused by a respiratory arrest followed by a cardiac arrest.
I see. In your report, you say about 2/3 of patients who, after admission to the ICU, who had resuscitation for an out-of-hospital cardiac arrest, so that group of patients, and who require a tube in their windpipe, 2/3 of them actually die from a brain injury,
Yes.
as opposed to any other cause.
Yes, so, and the reason for that is that most of your organs, even following a period of cardiac arrest, can recover. And the heart is far more hardy and less vulnerable, and the brain is particularly vulnerable. And we know this, that, if, these patients, their heartbeat will recover, their kidneys will recover and everything, but the brain's already irreversibly damaged. And it's one of the issues with CPR and resuscitation that it's common to be able to restart the heart, but the person doesn't wake up.
I see. In your report, and I'm looking here at paragraph 24, if we could pull that up, please. So INQ reference 5994, page 100, paragraph 24. I'd like to ask you about whether it's possible to say how long Dawn's brain was deprived of oxygen. So here in the report you say the other factor determining the extent of the injury is the duration of the arrest. The records suggest that Dawn's cardiac arrest occurred between about 10:14 and 10:27. But I think you've told us now that you've listened to the calls. You think it was about, pardon me, was that 10:22? Is that what you said?
10:20.
10:20, I see, okay.
Ish. So it could be 10:20, 10:21, Yeah.
And you've told us, in fact, the precise time isn't so important because there would have been a weak heartbeat before,
Yeah.
because she was there was no oxygen because she'd stopped breathing. And so you say she had a sustained heartbeat restored at about 10:51, according to the patient record, and 10:55, according to the Wiltshire Air Ambulance and hospital medical notes. And it was actually 10:57 in the ambulance call logs. So quite a few different data entry points, if I could put it that way. You say Dawn Sturgess may have had a transient and brief restoration at about 10:46 after a shock was given, but that a transient heartbeat during a resuscitation attempt, that is relatively common. And then on paragraph 25, you say the available timing suggests that the duration of the arrest was somewhere between 24 to 43 minutes before there was a sustained heartbeat. And as much as I'd hate to put you on the spot with maths, it looks as though if you listen to the call logs and the cardiac arrest it happened at about 10:20, then we're looking in the region of
31 to 37 minutes. Is that right?
I think so. We'll be corrected if we're wrong, but my note is about 30 minutes.
Yeah.
So that's Would you describe that? Is that, in your experience, caring for many patients in the intensive care unit who've had a cardiac arrest, is that quite a long time?
Yes, I think for a cardiac arrest that was caused by the breathing stopping, that's a significant duration of cardiac arrest and sufficient to cause a severe, irreversible hypoxic ischemic brain injury. And I think when you look at data from this, there's one other factor I think we didn't make and we didn't emphasise in the report, is that most good survivors from cardiac arrest have the sudden arrest, but you've also got to have it in a public place.
Yes.
Because you get multiple bystanders, as we've seen with you get multiple people coming to help, whereas a single person on their own at home, having to make the call, having to do the rescue, having to do the CPR, whereas if you're in a public place, you have several bystanders who are all doing things at the same time, and occasionally some of them will be trained in CPR or healthcare professionals. So having a respiratory arrest followed by a cardiac arrest at home, that, with a single bystander, and for that duration, the chance of survival would be vanishingly small.
And I suppose in the case of Dawn Sturgess, it's not a prime cardiac reason, as you said. Her chances of survival are made worse, are they, by the fact that her brain had been deprived of oxygen even before her heart stopped because of the breathing, the respiratory arrest. Is that right?
That's correct.
Are you able to tell us roughly, and I'm looking here at paragraph 25 of your report, what the survival rate is for such an injury?
So in 2018, for cardiac arrest treated by English ambulance services, which is different to they attended, because sometimes ambulance crews will attend someone who's died where they don't start CPR. So the ones where they've attempted CPR, as in Dawn Sturgess' case, the survival for those that had the same heart rhythm, which was asystole, that they saw in Dawn Sturgess' case, overall was 1.6%. But the ones who normally survive, of that 1.6%, are individuals who've had favourable circumstances, in that they may have been in a public place, they may have only just had their cardiac arrest, and so on, as opposed to Dawn Sturgess' circumstances. So hers would be significantly less than that 1.6%.
And would that 1.6% include people who'd had the heart attack running for the train, like the prime?
It would, yeah. And it's just that by the time the ambulance crew got there, they were flatlined, because all cardiac arrests ultimately lead to a flat line on the heart tracing, yes, irrespective of the initial cause.
Yes, thank you. If we can turn then to the evidence to support the existence of the brain injury to Dawn specifically. Looking at her records, what evidence is there to support the existence of the brain injury?
We'll start from the beginning, and she was comatose. So despite being on any drugs when she first came into hospital, she was unconscious, unresponsive. And that doesn't necessarily mean it was irreversible, but it's a starting point.
Yes.
And then her first brain scan showed early signs of brain injury, but they were subtle.
Yes,
and
we will. Sorry,
Yes.
we will go on to consider them in detail in just a moment. But you talked about sort of clinical signs like her being comatose, brain scans, and then I think the other part of the picture would be an EEG.
Yes.
Is that right? Can we just, before we begin going into these in detail, can you just tell us, brain scans, we've also heard them referred to as CT scans. What does that mean exactly?
Okay. I'll just go back one step, because when you prognosticate if someone's going to wake up or survive, you use what's called a multimodal approach. So you get information from multiple sources. So clinical is the first one, and that's the person's unconscious and not waking up. The second one is imaging, and imaging is things like X-rays and MRI scans of the brain. A specific type of scan is called a CT scan. I think CT stands for computer tomogram, and it's like where the patient is passed through a donut and it takes X-rays from multiple angles. And so that's an X-ray of the head that includes the brain, so a CT brain scan. So they're the two main. The third way is by measuring the electrical activity of the brain, which is measuring the brain waves, and that's by putting electrodes on the head and seeing what's going on. So if there was seizure activity, these electrodes on the head would pick it up. If there's no activity, it would also pick that up. And then there are things you can measure in the blood that aren't commonly used in the UK.
I see.
As well, but are used more commonly in other countries that are raised if there's brain damage.
I see. Thank you. The primary evidence that you've used in Dawn's case to consider the brain injury are the CT scans. I think that's right, isn't it? If we can turn now to your addendum report, which is reference 5995. If we begin at page 2. So, sir, to give you some background, the addendum report came about because in the original report, which we've just been looking at, the experts had said that there were 3 brain scans that happened during Dawn's intensive care stay, and that the experts had been given PDF copies of the scans, and they had asked if they could be reviewed by an expert consultant neuroradiologist to provide more detailed information about the severity of the brain injury. And that is what happened. Is that right?
Yes, and the important thing is that the consultant neuroradiologist got the actual images, and the images are computerized and was able to look at them on. So we just had prints which aren't very good at looking at. And so he looked at them on the right software, and then they can manipulate them and turn up the brightness and change the settings and look at the bones, the bits of the brain, and do measurements on it. And that's what their full-time role is.
Yes.
And the particular neuroradiologist, Dr. Minks, is one of my colleagues in Bristol, and I asked for permission and wrote him a set of questions.
Yes.
And he's the person I work with on a daily basis, and so our interaction was I tell him a bit of a story and ask questions, and he answers them based on his review of the scans. And Professor Nolan and I did that with him, and then produced this report.
Yes, thank you. We will hear from Dr. Minks.
Yeah, but this additional report is with the input of Dr. Minks, is that it?
Yes, that's correct.
Got it.
Yes, and in fact, we can see you very helpfully attached at page 6 onwards a record of your discussions with Dr. Minks, and we can see you reviewing the scans together, in effect, the questions you ask him and his responses to them. Yes, that's from page 6 on to page 12 of the document. I'm referring to the INQ pages here, not the internal documents. And then the images themselves are at the end.
Yeah, I think he took some example images just to
Yes.
show us how he'd done the measurements.
Yes. I'm not going to take you to those images
Yes.
today. We're going to explore them with Dr. Minks when he attends. But I'd like to just briefly ask you about, from the scans and your discussions with Dr. Minks, what your conclusions are about the existence of the brain injury. So if we begin with the first scan of Dawn's brain was done about 2 hours after her resumption of spontaneous circulation. And if we look, yes, so just at the bottom of page 1 of that report, you see the first scan, I think on the next page, which is page 2, says this scan shows early signs of post-cardiac arrest, global hypoxic ischemic brain injury. Do you see that?
Yes, that's
Yes.
correct. Yes.
So could you just tell us, looking at the first scan, just give us a bit more detail about what your conclusions are now?
Yeah. So the first scan was done very early, and just as if we get kicked and we get a bruise, you don't see the bruise straight away. This scan was taken 2 hours after the cardiac arrest, so it only shows subtle signs of a hypoxic ischemic brain injury in that it doesn't show much swelling, but in a normal brain, the grey matter and white matter is very distinct from each other, and with brain injuries, the brain gets bruised and swollen. Water moves into cells until they both start looking the same, and you get this loss of what's called grey-white differentiation.
I see.
So they become distinct. They become less distinct from each other.
Yes.
And there's certain parts of the brain which are more vulnerable to a lack of oxygen and a lack of blood flow, and that's the areas that are of particular interest, or the radiologists call them regions of interest in the brain, because they're the ones that show this loss of distinctness best
I see.
in terms of brain damage. And when we reviewed this scan, the report in the notes said it was normal. Dr. Minks, who's a specialist neuroradiologist who looks at brain scans all the time, did the measurements and actually said it showed early changes of hypoxic ischemic brain injury.
I see. In your original report, and I'm looking here at the paragraph D on page 2, you said an early brain scan is often normal under cardiac arrest, even in those patients who have sustained a hypoxic ischemic brain injury. This is because the brain injury, including brain swelling, typically develops over several hours and might not be clearly seen until 48 to 72 hours later. So, as you described, the scan that was done in the hospital, there were notes in Dawn's medical records from the review of the scan at the time. They didn't note any changes. And so in your first report, I suppose you were taking that at face value. And now, having discussed it with Dr. Minks, you've changed your opinion based on his assessment that there are changes, but they're subtle.
Yes,
Is that right?
so although the issue that brain injury takes time to develop, a detailed review of the first scan showed that the severity of hypoxic ischemic brain injury was probably worse than we thought,
I see.
based on just looking at the reports in the notes.
Yes, I see. So originally you looked at the reports and the notes and you took them at face value, and now you realize the injury was more serious because an expert has looked at them and confirmed there is evidence there.
Early signs of injury, which things are worse than we thought.
Yes, I see.
Yeah.
I see. Now, if I take you to the second scan, just paragraph 6 on the same page. Can you take us through your updated opinion based on the second scan of Dawn's brain performed on the 6th of July?
Okay, so by the 6th of July, Dawn Sturgess was still sedated and ventilated, and she had had some of these brain EEG monitoring looking at the brain activity on 2 occasions with no sedation on, and with the sedation off, she remained comatose, and her EEG activity was flat, so there was no electrical activity in the brain, which is a poor sign. So she had 2 signs that pointed towards a severe brain injury. One was that she was comatose, and one that she had a flat EEG. But neither of those signs are infallible, because she could have been asleep because the drugs hadn't worn off, an effect of Novichok we're not aware of. And again, the EEG could be flat because the drug she was on, or the stickers weren't on properly, lots of reasons. So the brain scan actually gives you like the photograph of the brain to show you what the extent of the damage is. And the scan on the 6th showed that the hypoxic ischemic brain injury had progressed, such that in Dr. Mink's words, such that there was a severe advanced global hypoxic ischemic brain injury. And there were areas of dead brain on the scan that had become swollen due to ingress of water into those dead areas. So that grey-white matter differentiation had completely been lost. And the brain was swollen, and the brain sits inside the skull, which is like a box, and it had become very tight and squeezed inside that box.
I see.
And there was also an unexpected finding, which was a bleed or a brain hemorrhage on the scan, which, following our discussions with Dr. Minks, Professor Nolan and I, and he thought that the most likely cause of this was a bleed into a dying area of dead brain, or a dying area of brain or an area of dead brain. So the bleed was caused by the severity of the hypoxic ischemic brain injury rather than a primary effect of Novichok.
I see. I'm going to ask you a little bit later about the cause of the bleed. But for now, focusing on the hypoxic ischemic injury, you said that it showed evidence of a global.
Yeah.
Does that, probably quite a basic question, but that means that the injury was to all parts of the brain, is that right?
Yes, the whole brain. So when people have a stroke and they have a weak arm, only a portion of the brain's damaged, and that can be recovered with treatment. When the heart stops beating, the whole of the brain's starved of oxygen and blood flow. So the injury you get is global, but within the brain, there's some certain regions that are very oxygen and blood flow hungry,
Yes.
that are more vulnerable. So different regions have a different vulnerability. So if you manage to damage your whole brain, well, that's a sign of a severe insult.
Yes. Well, I suppose my next question was going to be the prognosis for somebody with a global injury. Would that be worse than somebody who has an injury only to part of the brain?
Yes, that's correct. It would depend on which part of the brain, because there's some parts of the brain that are very mission critical and others less so. But a global injury that affects the whole brain is not good in terms of survival.
Yes. Okay. I'm just going to ask you quickly now about the third scan. And here you deal with this at paragraph 7 of your addendum report. Can you tell us what your opinion is based on the third scan, which occurred on the 7th of July?
Yeah. So the first scan was on day 1. The second scan was on day 7 on the ITU. The third scan was on day 8. And so there's guidance for intensive care units that if you identify someone with a devastating brain injury, as Dawn Sturgess was, you normally wait a while just to be absolutely certain and do another scan, make sure they're not waking up. And so this scan was just done as an interval scan the next day.
I see.
That just showed things were worse than the day before.
I see.
And the bleed had got worse, and the extent of the dying and dead brain had got worse.
I see. And you say in your report that you've updated your opinion from the original report to say that she had no possibility of survival at that stage. Is that right?
Yes, that's correct.
Okay. And pardon me, if we go back to paragraph 6, your conclusions for the second scan, you mentioned the brain hemorrhage, which we'll talk about in a little more detail in a moment, but was your opinion that after that, as a result of the information in that second scan, that there was any possibility of survival for Dawn?
Yes, so as I've written, when we originally gave an opinion, we hadn't seen or discussed the scans in detail, so we're relying on the local reports and not the images.
Yes.
But once we'd discussed them with a neuroradiologist, and what we did isn't extraordinary, because that's what you do in real life. You know, when we have patients on our ICU, we discuss them with a neuroradiologist.
Yes.
We examine the patient, we discuss the scans, we look at all the results, and then pull that story together. And because we now had a more detailed story, our opinion now was that there was no possibility of Dawn Sturgess surviving based on that second scan on day 8.
Yes.
Or day 7, sorry.
Okay. And now I'm going to ask you a bit more about the hemorrhage, including the cause and the effect on survivability. You deal with the hemorrhage in your first report at page 105, paragraph 37. We don't need to pull that up, but it's for your reference, Dr. Soar, because in fact, I'm going to ask that we pull up an image which we saw yesterday with Professor Rutty. It's just a representation of the hemorrhage. It's reference 5818, page 5. If we could just pull that up, please. Thank you very much. So this image was shown to us by Dr. Rutty yesterday, so I appreciate it. It's not your image. And he explained to us that because the scan is taken from the feet first, the bleed, which we can see represented by that circle, was actually on the left side, but here it appears on the right.
Yeah, I think his photo, with this photograph is, when we look at scans, you look at them as if you're standing at the foot end of the patient.
Yes.
Scans, yes, but this, no.
Yes.
Yeah.
So I think it doesn't matter for, you
No.
know, for this opinion.
No, but we can see here represented the circle, which is where the hemorrhage was. And then on the right-hand side, we can see a different cross-section of the brain showing that bleed close to the brain stem. So what I want to ask you, and I'll refer you to paragraph 37 of your report, you say that the scan on the 6th of July unexpectedly showed that Dawn had a brain hemorrhage. Is that right?
That's correct.
Okay. And the report by the consultant radiologist showed a large intraparenchymal hemorrhage. Is that right?
Intraparenchymal just means it's happened within the brain tissue as opposed to on top of it or somewhere else.
I see. And it's centered on the left basal ganglia and left frontal lobe.
Yeah.
And so the left basal ganglia, we can actually see that in Professor Rutty's image. That's just a part of the brain.
Yeah, and it's an important part of the brain because it's a sort of major thoroughfare of lots of tracts, things that make you move or feel things. So it's a very important part of the brain.
Okay. And the report also described swelling and a bleed extending into the left midbrain,
Yes.
causing the left brain to shift to the right by about 11 millimeters. Can you just tell us what would be the effect of such a bleed on the brain?
Yeah. So I think if this was just the bleed, and because I think there's two processes going on in Dawn Sturgess' brain, and that
Yes.
she had the hypoxic ischemic brain injury causing the global insult, and then this was, as I've said already, in our opinion, just a secondary bleed into an area of dying brain.
Yes.
But if this had been a bleed on its own, the movement of, it would have led to loss of consciousness and unwellness. But it's hard to say what it would have done on its own because everybody presents slightly differently.
I see.
The important thing is that I don't have a model in front of me, but the inside of the brain, the skull, has lots of sharp edges and and when the brain moves and swells, lots of parts of the brain get trapped or squeezed and squashed. So that bleed on its own would cause the pupil to go up on that side. It cause loss of consciousness. The midbrain is involved in consciousness and quite a lot of activity. So it could lead to anything from someone becoming unconscious all the way to death on its own, actually.
I see.
Depending on the circumstances.
I see. And discussions with the neurosurgeon, this is at the time that Dawn was in the
Yes.
hospital, in Southampton took place, and it was agreed that no specific treatment would help Dawn at that time. Do you agree with that assessment?
Yes, in that the combination of issues of a global hypoxic ischemic brain injury, which, as I've said, on its own was probably sufficient to have caused death. Now, with a significant amount of dying brain, with a bleed, would have been, certainly unsurvivable. And I don't think there's any treatment that is readily available to treat this, unfortunately.
We can take this very briefly. The further scan done a day later, which we discussed on the 7th of July, it showed that the blood clot had extended further, involving the brain stem and the posterior fossa, if I pronounce that correctly.
Fossa, yeah.
Fossa.
So basically, the brain sits inside the skull, and there's 3 steps. And the frontal part sits in the frontal fossa, the middle bit in the middle bit, and the posterior bit in the posterior fossa. Yeah, and so that's just how it's described. So it just tells us that the blood has spread, the brain's got tighter within the skull, and is being squeezed.
I see.
Yeah, and so it just tells us that things are worse than the day before.
Yes. So you had said before that it was unsurvivable, and it was even worse
Yeah.
on the 7th of July. Okay.
Yes.
Now, I'd just like to explore with you the cause of the hemorrhage. Now, you've told us already that you think it's a secondary injury, so caused by the primary injury, which is the hypoxic ischemic brain injury. Is that right?
Yes, that's correct. So when Professor Nolan and I discuss these scans with Dr. Minks, and he's an interventional radiologist, and he treats strokes and bleeds and these sorts of things. And his feeling, and we tend to agree with it, was that the brain had already been badly damaged at the time the bleed occurred, and this bleed occurred in an area of brain that was dying because that part of the brain is particularly vulnerable to being starved from oxygen, and also its blood supply is quite tenuous, and there's lots of these tiny blood vessels that go into that area that have sort of blind ending ends, and once that brain starts dying, there'll be bleeding into that area.
Okay. So once that part of the brain starts dying, you're saying there'd be nowhere for the blood to go
Yeah.
that would escape, causing a bleed.
Sure.
Is that right?
Probably. I think you'd probably need to corroborate that with Dr. Minks.
I see.
And he would probably be able to name all those blood vessels and tell you where they were.
Yes. Well, we will ask him. Professor Ruddy's opinion was, I think, also that the bleed was caused by, he said, hemorrhagic transformation of an injured part of the brain. Put simply, injured and dying, a dead brain from a lack of oxygen is at risk of dying, of bleeding, pardon me. So I think his opinion was that the bleed was caused by the primary injury, which was the hypoxic ischemia.
So his opinion aligns with my opinion. I think he's put
Yes.
it in a better hemorrhagic transformation of a dying brain or a dead brain.
Okay, so it's the same thing.
Yes.
Okay, thank you very much.
I think hemorrhagic just means bleeding.
Yes. I'd like to just canvass with you evidence that we heard from FT49. So he gave evidence on the 31st of October, and I'll just read to you what he said. He said, "It is possible that, or it's likely that nerve agent contributed to damage to the lining of the brain because, as I mentioned in my statement earlier, it's highly lipid soluble. It likes, I think, to get into lipid tissues, and one of the densest lipid tissues in humans is the brain. So that passage of nerve agent to the brain, as well as generating seizure activity, will have damaged the integrity of vessel walls within the brain." And then the question to him was, if that's right, and if the nerve agent had done that damage to the brain, would that, tell me yes or no, right or wrong, but might that have made the brain even less tolerant than it would otherwise have been to the starvation of oxygen? And the answer was yes. Do you agree, or can you comment on whether you think FT49 is correct that the Novichok being in Dawn's body and in her brain, whether that would have contributed to the bleed?
First of all, we wouldn't have access to the information on Novichok that FT49 does. Secondly, from the other cases, that didn't appear to have happened. Yeah, so there's 4 or 5 other cases. So first of all, so all drugs that get to nerve endings, muscles and brains must be lipid soluble, and we know that it was lipid soluble because it got to a lot of places. In Dawn Sturgess' case, because she'd had the cardiac arrest and the process of brain damage had started, the blood-brain barrier, which people may have talked about, becomes leaky straight from the start. So drugs that wouldn't normally get to the brain probably do get to the brain in greater amounts than otherwise. But what we're seeing, I think, could be explained without any effect of Novichok.
I see.
Clearly, I can't rule out an
without any
effect.
direct effect of Novichok on the tissue of the brain, is that it?
Yes, so what we're seeing could have happened irrespective of the Novichok. Whether Novichok has some added actions, I would not know.
Yes, but of course, when you say irrespective of the Novichok, you don't. That includes, doesn't it, that she had the cardiorespiratory arrest because of Novichok,
Yes,
but you mean without the direct action.
Sure, and
Yeah.
the other point is that the cardiac arrest hypoxic ischemic brain injury could cause that severity of brain injury followed by the bleed into the dying brain. In clinical practice, it's not seen very commonly, largely because when someone has an explained cause of their cardiac arrest that isn't Novichok, these scans and things would have been done much earlier. And so if Dawn Sturgess hadn't woken up at day 3 or 4, and she'd had the scan and it had shown a global hypoxic ischemic brain injury, things would have moved to withdrawal of life support possibly before the bleed had even happened.
I see.
We don't know precisely when it happened.
I see. So in Dawn's records, and in your initial report, you describe it as a kind of unexpected bleed. And are you now saying that one reason why we might have observed the bleed is because she had been kept on life support for a longer period? Is that what you're saying?
8 or 9 days is quite a long time
In your experience?
for someone who, most people, if they weren't waking up day 3 or 4, you'd do a scan.
I see.
And if it was showing a severe global hypoxic ischemic brain injury and they weren't waking up, you might do some other tests like the EEG, and you can do other tests of looking at different nerve pathways in the brain. And if they all point towards a severe injury, you'd move to withdrawal of life support much earlier than that. So you may not be seeing these bleeds that may occur later on. And that's no criticism of the team looking after Dawn Sturgess, in that they had good reasons to keep on treating her while they were working out what was going on.
Yes.
And to be absolutely certain they were doing the right things.
Yes. Thank you. You told us that there would be 3 sort of sources of information for the brain injury. First, clinical signs. Second, imaging. And third, electrical activity. I'd like to ask you now about the electrical activity. So those were in Dawn's records, the EEG scans. Is that right? Can you just tell us what EEG stands for?
So EEG stands for electroencephalogram. And basically, it's like doing a heart tracing, but for the brain, and electrodes are stuck to the head. And then the electrical signals from the brain are collected, and you can put 24 on or 12 and different points, and they look at the brain from different angles, and you get these wiggly traces. And in normal people, the EEG varies according to your conscious level. So when you're awake, it may be more active than when you're asleep, and that's where things like different depth of sleep and so on, and also in brain injury. And then anaesthetic drugs or sedative drugs will also change EEG.
I see.
So it has quite a lot of confounders in that it gives you an answer, but most reports come back with what the EEG shows, and then this could be compatible with X, Y, and Z. Clinician to, interpret in context of a clinical scenario. So in Dawn Sturgess' case, she had 2 EEGs. The first was on the 2nd of July, and the sedative drugs were off, so she wasn't on any drugs that can suppress the EEG, and it showed what's called a very low voltage EEG, and there was no reactivity. So when someone spoke to her or gave her a painful stimulus, it wasn't registering on the EEG.
I see.
And the second EEG was on the 5th of July, which showed the same. And so that's not a good sign, but it's not foolproof. In that, if a temperature was low that day, or the drugs hadn't worn off properly, it wouldn't. So you wouldn't rely on the EEG alone. And a brain scan that shows evidence of severe damage is where you look at as being far more informative.
Yes.
To the extent of brain injury. And the EEG just adds a little bit of support to that. On that EEG alone, you'd probably think things might be okay. You can't 100% rule out some recovery.
Well, I think I can anticipate the answer to this next question, but in your first report, you mentioned the possibility of a further review of the EEG by a neurophysiologist. But following the review of the CT scans, the brain scans, do you think that's still necessary?
No, I don't think it's necessary. I think they were reported by a neurophysiologist, and I assume the neurophysiologist who reported these scans in the hospital had also seen EEGs on others who may have had Novichok. I don't know if they did have EEGs or not, but it's probably the place in the world where they've got the most experience of looking at EEGs
Yes.
on this sort of patient. And we know from the German case, the EEGs were never abnormal. So the EEGs in Dawn Sturgess' case are probably indicative of a severe brain injury, but not on their own. It's the scan that is the key bit of information.
I see. And I think you've said in your addendum report that the brain scan provides, pardon me, in your addendum report you say there's no need to have a further review of the EEG scans because taken together with the brain scans, that provides unequivocal evidence of a severe hypoxic ischemic brain injury. And that's for your notes, sir, at page 4, paragraph 10 of the addendum.
Yes. And I think the post-mortem findings also confirmed, downstream that there was a severe hypoxic
Yes.
ischemic brain injury.
Yes, that's right.
I think the brain scans help to tell us that it happened relatively early in the process and not post-mortem, so to speak.
Yes. And one final question just before we move off this topic. We've heard the cause of that brain injury is the lack of oxygen.
And blood flow.
And blood flow, yes, pardon me.
So hypoxic ischemic brain injury.
Yes. And so it follows that Novichok on its own wouldn't cause such an injury to the brain. Is that right?
Not based on the other cases we've seen.
Okay. Thank you very much. So I have another few topics to move on to. I don't know if it would be better now to pause for lunch.
What you mean is it would be, you think it probably would?
Well,
Yes.
it's better to
Well,
stop.
you're in control of the progress of the examination, Miss Pottle. If that's your judgment, we'll do that. Can we resume then, please, at just before 1, 5 to 1, 5 to 2, I should say, 5 to 2. In fact, 1:45 will do fine, won't it?
Yes, I think so.
1:45. I'm sorry, I'm misreading the clock. 1:45.